Hi, my name is Tiffany. I am a student in the Master of Social Work program at the University of Missouri at Kansas City, and I am doing this brief film for my psychopathology class. And I'm here to talk about schizophrenia today. And I have a very personal reason for wanting to do that. My grandma, maternal grandmother, Henrietta Viola Matouche Garner Everett, was born February 23rd, 1925. And as my mom was growing up in her household, Henrietta worked at the civil service at the Veterans Hospital and also at Fort Hood, which is close to where my mom grew up. And when Grandma was 43 years old, she attacked a person that she worked with, thinking that they had said something, but the person hadn't said anything. And according to Mom, she was having a spell, and she lost her job, and she was hospitalized after that. When she was admitted to the hospital, Grandma was diagnosed with schizophrenia as well as OCD and major depressive disorder. So let's talk a little bit about what it means to have a diagnosis of schizophrenia and what has to be present for that diagnosis to happen. Schizophrenia, in order to be diagnosed, you have to have two or more of the following: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms, such as the absence or reduction of normal behaviors, emotions, and motivations. So, a lack of drive, reduced emotional expression, inability to feel pleasure, social withdrawal. To be diagnosed with schizophrenia, you must have one of the first three. So, delusions, hallucinations, or disorganized speech must be present for the diagnosis. And you have to have them for at least 1 month in length. Additionally, the level of functioning in one or more major areas in the person's life has to be really below the level that they were functioning at prior to the onset of schizophrenia. Additionally, if it's a child we're talking about, then they would need to be functioning at a different level than you would expect, at a much lower level than you would expect them to be at under normal circumstances for who they are. There have to be continuous signs of disturbance for at least 6 total months, with at least 1 month of the symptoms that we talked about. And there can be periods, prodromal or residual periods during that 6 months, where things are still a little bit off, but maybe they're not experiencing the same symptoms to the same level. There are some other disorders that need to be ruled out before a diagnosis can be made, and those are schizoaffective disorder and depressive or bipolar disorder with psychotic features. We'll talk a little bit more about those here in just a minute. Additionally, the disturbance can't be attributable to the physiological effects of substances or another medication. So it can't be because you're altered in some way or fashion. That's not due to the schizophrenia. Also, if there is a history of other psychiatric disorders, an additional diagnosis can only be made if the symptoms for schizophrenia are present for more than 1 month. So earlier I mentioned a couple of diagnoses that would be similar and need to be ruled out before something can be considered schizophrenia. Let's talk about a few of those here. So some diagnoses that would be similar but not the same as schizophrenia: major depressive or bipolar disorder with psychotic or catatonic features. These disorders, the delusions and hallucinations only happen during a major depressive or a manic episode. They're not present for the entire duration of time, like you would need to see in schizophrenia. Schizoaffective disorder is another one, and this means that mood symptoms, such as, depression or manic, are only present during the majority of duration of active delusions or hallucinations. So it's kind of a selective type situation. Schizophreniform or brief psychotic disorder can be ruled out due to their time length because they are much shorter duration than schizophrenia. Additionally, there's delusional disorder, which has delusions but is absent the other symptoms of schizophrenia. Some other similar diagnoses would be obsessive compulsive disorder or body dysmorphic disorder. It can present as poor or absent insight and preoccupation that reaches delusional proportions, but the preoccupations are specifically with your appearance, your body odor, with hoarding, or their body-focused repetitive behaviors. Another one is PTSD, and a lot of times someone having a flashback can be hallucinating, or they could be hypervigilant to the point of paranoia, but this is all a callback to a traumatic event, and that's what rules it out. Another is autism spectrum disorder, where sometimes the symptoms might resemble a psychotic episode, and it's entirely possible that someone who is autistic can also be schizophrenic, can be a comorbid condition. Some other similar diagnoses can be other mental disorders that are associated with a psychotic episode. Just remember that schizophrenia is persistent and it can't be attributed to the effects of a substance or another medical condition. So schizophrenia has to last a long time before 6 months before it can be diagnosed, and that really is what makes the difference there. Additionally, substance or medication induced psychotic disorder is distinguished by the relationship of the substance to the onset and remission of the psychosis. So when you're using something and you're having psychosis, then it's probably attributable to it if it's not present when you're not using it. So between 0.3% and 0.7% of the total population has schizophrenia, and there is increased prevalence in some groups. It's based on migration or refugee status, urbanacity, economic status, and the latitude of the country they live in. We'll talk more about some of the reasons that's true in the next few slides. The sex ratio does differ in different populations, but there's no big difference globally, so as many men as women have schizophrenia. So this is the important one. Remember that I said my grandma ended up going to the hospital and being inpatient after attacking someone while she was working, and because of that, she lost her job on the Army base. So schizophrenia has some pretty strong potential impacts to social functioning, pretty significant social and occupational dysfunction. To quote from one of my resources, patients often suffer from unemployment and are homeless. Additionally, there are deficits found in reading ability, basically because disorganized brains have a hard time reading, and it's kind of like an acquired dyslexia that's due to having the disorder. Individuals are often employed at lower rates than their parents or at lower jobs, lower economic types of jobs than their parents. And a lot of people who have schizophrenia don't marry and have limited social contacts outside of their family. So this is where things get really interesting because genetics are a big factor when it comes to schizophrenia. Very strong risk factor. It's highly heritable, estimated at about 80%. So if you have it, you probably have a relative who has it. But the genetic architecture is really complex, heterogeneous, and polygenic. They've identified, I think at this point, the last research I saw, over 300 different genes that this might be affecting. And so we can't just narrow it down to one. And additionally, that risk, that genetic risk, is shared between schizophrenia, bipolar, sometimes autism, and other disorders, which basically means that some of these genetic variations that we see that could indicate schizophrenia could also just indicate a general genetic vulnerability to mental disorders. So that's part of it. The other part of it is that there are early life environmental risk factors, according to several of the sources that I've cited. Specifically, obstetric complications in birth, a winter birth in the Northern Hemisphere, urban living, childhood trauma, migration, and interestingly, cannabis use. It doesn't specify whether that was used by the parents of the baby or of the person after they were born. Meaning that there is a convergence of genetic and also environmental risks. When they do converge, it's up to 5 times greater risk of being diagnosed with schizophrenia than if you would have one or the other. And as we talked about before, it's polygenic, and it especially appears when there's family psychiatric history and parental socioeconomic status at birth being diminished. And finally, let's talk a little bit about interventions that can be used when somebody has been diagnosed with schizophrenia. So there's evidence that strongly supports the use of family interventions, working on communication skills, problem solving, and doing some psychoeducation, as well as supported employment programs, cognitive behavioral therapy, social skills training, life skills training, and patient education, all of which have been found to be effective in the treatment. In addition to psychosocial interventions, there are also pharmacological ones, and usually the second generation antipsychotic drugs are used right now. They basically block the dopamine receptor, and they're generally effective for about half of patients who have schizophrenia. They work better for positive symptoms than for negative or cognitive symptoms. And sometimes these medications can have severe neurological or metabolic side effects too. There's another medication, I think it's called clozapine. I could be mispronouncing that. And there are about a third of all schizophrenic people who are resistant to the medications, although we don't really know why. And it's not really well understood why clozapine works. But it's only used in the most severe and resistant cases because it has a really significant potential side effect risk of agranulocytosis, which basically means that you don't have very much of an immune system at the time that you're taking it, which can be really dangerous. There is further research needed into disrupting the mechanical mechanisms of cognitive and the negative symptoms. Some of the new research has said that the cortical excitatory inhibitory imbalance, meaning that your brain either gets really excited or it just shuts down, is part of this. That there's aberrant synaptic pruning going on, meaning that your body is pruning the wrong synapses, or that there's dysfunctional interneuron signaling. So part of your brain is just not working the way that it's supposed to work. And they are researching medications that could potentially disrupt some of those mechanisms or regulate them back to being more normal. A third intervention that I found an article about that was really interesting talks about exercise therapy improving both positive and negative symptoms, quality of life, cognition, and hippocampal plasticity and volume in the brains of persons who have schizophrenia. Now, separating these effects from what exercise would do for people who don't have schizophrenia is kind of difficult. It's hard to tell what's treating the schizophrenia and what is in general helping people be healthier. But either way, people who've been diagnosed with schizophrenia have seen good results with exercise therapy, and it can also be used together with medications, cognitive behavioral therapy, and any other treatments. So to wrap up the story about my grandma, Henrietta, my mom was 16 years old when grandma was diagnosed with schizophrenia. And I think my mom had always known that there was something wrong, but not exactly what it was. And after the diagnosis, Mom was a teenager and didn't really pay a whole lot of attention, I think. She was more focused on, high school and boys and all those kinds of things. So I asked her what it was like to move back. Because in 2001, my mom moved back in with her mom. My mom was 50, and Grandma Henrietta was 76. And Mom said that it was easier for her as an adult to be with Grandma because she knew that she was sick and she knew the symptoms to look for, what the symptoms were for her delusions. And she did have delusions. She did have hallucinations and a lot of positive symptoms. Throughout the last 14 years of her life, when Mom lived with her, Grandma went to the psychiatrist every 2 weeks and was on multiple medications. And in between 2001 and when she passed in 2014, she did change meds multiple times because the medications would become ineffective. So in closing, I just want to say thank you for joining me today and taking the time to understand your family member or loved one's disorder, because understanding it can allow you to be more compassionate in your care and more understanding and empathetic in the love that you give. And also a big thank you to my mom for sharing all of this information with me and the family pictures that I've been showing you guys.